Hello everyone, this is Dr. Deptee Warikoo, Department of Physiotherapy, Dolphin PG Institute of Biomedical and Natural Sciences. Our today's topic is ankle complex. In this class, we will be dealing with the ankle joint, the subtalar joint and the mid-tarsal joints. We all know that these joints are starting from the ankle towards the foot. We have the basic bone, the talus, which articulates with tibia and fibula, then the calcaneum, then the navicular, the cuboid, and the three cuneiforms. These articulate together to form ankle joint, subtalar, and the mid-tarsal joints. So this is the basic structure of the ankle, which you could see here. This is the ankle joint, the talocrural joint, the subtalar, and the mid-tarsal joints, which we will be dealing here. The ankle and foot complex is structurally analogous to the wrist-hand complex to the upper extremity. But there are lots of differences. The complementing structures of the foot allow the foot to sustain large weight-bearing stresses under a variety of surfaces and activities that maximize the stability and mobility of the foot. This you can see in the slide, the stability demands and the mobility demands, which are well nicely given by the ankle and foot complex. So the joints which are associated basically with ankle are first the tibiofibular joint, that is the proximal and distal tibiofibular joints, and the talocrural joint. So when we talk about the proximal tibiofibular joint, it is a plain synovial joint. The fibula head articulates with posterior lateral aspect of the tibia, and the basic motions over this joint are the superior and inferior sliding of the fibula and the fibular rotations. So the ligaments over this joint are basically the joint capsule, which is strengthened by anterior and posterior ligaments and the tendons of the popliteus muscle. There is firm stabilization needed for effective transfer of forces exerted through the muscles like biceps femoris and the lateral collateral ligament of the knee. Then we have the distal tibiofibular joint, which works which works along with your talocrural joint. So this is the syndesmosis or fibrous union between the concave surface of tibia and convex facet of fibula. Both the bones are separated by fibroadipose tissues. The ligaments present over the distal tibiofibular joint are anterior and posterior talofibular ligaments, the inferior transverse ligament, and the interosseous ligament, which is the strongest one, which you could see in this, the present between the both. This is the interosseous ligament. This you could see here, present between the tibia and the fibula. It is the strongest and holds both bones together. Now we talk about the ankle joint or the talocrural joint, which is your basic joint of today. The term ankle refers specially to this talocrural joint, which is the joint between distal tibia and fibula proximally and the body of the talus distally. Here you could see this joint. So it is basically the synovial hinge joint with a joint capsule and associated ligaments. You could see the proximal articulating surfaces are the concave surface of the tibia, the tibial and fibular malleoli. So we call them together, the talocrural, as the mortise. The mortise, that is the tibia, the fibula and the two malleoli. Here you could see this is the mortise. This is how it forms. You could see it here. The structure of the distal tibia and malleoli resembles and is referred to as your mortise. Then the distal articulating surface is formed by body of the talus, which consists of superior or trochlear surface, medial surface, and lateral surface. Now the capsule and the ligaments. First the capsule, the joint capsule of the ankle joint is fairly thin and especially weak anteriorly and posteriorly. Therefore, the stability of the ankle depends on an intact ligamentous structure. The ligaments that support the proximal and distal talofibular joint are important for stability of the mortise and therefore for stability of ankle itself. So we see it is anterior posteriorly thin and it is thick medially and laterally. So if we see the attachments, proximally it is attached to the border of tibia and malleoli and distally to the margins of the trochlear surface. Then we move to the ligaments of the ankle joint. So we have lateral collateral ligaments, medial collateral ligaments, and the accessory ligaments. The lateral collateral ligament, consists of anterior talofibular ligament, posterior talofibular ligament, and calcaneofibular ligament. The medial collateral ligament consists of superior fibers, that is the deltoid ligament, the deep fibers, that is anterior and posterior talotibial ligament. Accessory ligaments are also there, which has an anterior ligament and a posterior ligament. So first we start off with the lateral collateral ligament. We have the anterior talofibular ligament here, which is from the anterior margins of the fibular malleolus between lateral articulating facet and sinus tarsi and oriented obliquely and inferiorly and anteriorly. Here in this diagram, you could see this is the anterior talofibular ligament. Then we have the posterior talofibular ligament. It is from the medial surface of the lateral malleolus, posterior lateral tubercle of the talus and runs horizontally, medially and posteriorly. This is the posterior talofibular ligament. Then we have the calcaneofibular ligament. It is present at the depression in front of the lateral malleolar apex to lateral surface of the calcaneus. It runs obliquely, inferiorly and posteriorly. In this diagram, you could see the calcaneofibular ligament. Then the medial collateral ligaments. First is the anterior talotibial ligament. It is from the anterior tibial malleolus to medial aspect of the neck of calcaneum. It runs obliquely, inferiorly and anteriorly. Then we have the posterior talotibial ligament from the posterior surface of the tibial malleolus to medial surface of the calcaneum and runs obliquely, inferiorly and posteriorly. Here you could see the ligaments. This is the Achilles tendon, the posterior talofibular ligament. This is the calcaneum, the talus and the fibular head. And this is posterior talofibular ligament. Then we have the deltoid ligament. It is the medial ligament from medial malleolus to the navicular tuberosity. The medial margin of plantar calcaneonavicular ligament is along there and substantia tali also. You could see it here. This is the tibia, the navicular. This is the tibialis anterior tendon, the talus, the tibialis posterior tendon you could see here. And then you could see these are the margins. You can see this is the deltoid ligament. You can see the margins and the deltoid ligament. See here, you can also see this is the deltoid ligament. This is a strong one ligament, holds the ankle very nicely. Then we have the accessory ligaments. The anterior ligament from anterior lower margin of tibia to the upper surface of the neck of talus. And this ligament is obliquely oriented. Then we have the posterior ligament attached over the tibia and fibula and converge to posterior medial tubercle of the talus. Now we will discuss about the muscles of the lower leg and the ankle. There are 4 compartments that make the lower leg operate properly. Any injury to these compartments can cause swelling or any nerve damage or anything. First we will see the anterior compartment. This is the anterior compartment. The muscles in the anterior compartment are anterior tibialis, extensor hallucis longus, extensor digitorum longus, anterior tibial nerve, anterior tibial artery and dorsiflexus of the foot. These are the structures present in the anterior compartment. Then the lateral compartment, we have aortas of the foot, peroneus longus, peroneus brevis, tertius and also contains superficial peroneal nerve. Then the posterior compartment, the superficial group, posteriorly we have a superficial group and a deep group. The superficial group has the plantar flexors, the gastrocnemius, soleus. Then the deep group has got the deep plantar flexors, that is tibialis posterior, flexor hallucis longus, flexor digitorum longus, posterior tibial artery. So these are the basic structures. Then the blood vessels. The ankle gets blood from nearby arteries that passes by the ankle on their way to the foot. The dorsalis pedis runs in front of the ankle to top of the foot. You can also feel it. You palpate it also for the pulse. Then another large artery is called the posterior tibial artery, which runs behind the medial malleolus. It sends smaller blood vessels to inside edge of the ankle joint. Other less important arteries could also be seen. We could see that. I'll show you a picture. These are the basic arteries. You could see the dorsalis pedis artery, the lateral plantar artery, dorsal metatarsal and digital arteries. These are the basic blood circulation around the ankle and foot. Now the nerve supply. The nerve supply of the ankle is from nerves that pass by the ankle on their way into the foot. The main is the tibial nerve, which runs behind the medial malleolus. Another nerve which crosses in front of the ankle on its way to top of the foot. There is also a nerve that passes along the outer edge of the ankle, which we could see right now in the diagram. You could see here. This is the tibial nerve. Here you could see it passing the plantar nerve. Then the deep peroneal nerve, the lateral plantar nerves, and the intermediate cutaneous nerves. Now about the muscles of the lower limb and what actions they are doing it. So we know the actions of the foot are plantar flexion, dorsiflexion, inversion, eversion basically. So plantar flexion of the ankle is mainly done by gastrocnemius, soleus, plantaris, flexor digitorum longus, peroneus brevis, flexor hallucis longus, and tibialis posterior. Dorsiflexion is done by tibialis anterior, extensor digitorum longus, extensor hallucis longus, and peroneus tertius. Inversion by the tibialis posterior, flexor digitorum longus, flexor hallucis longus, tibialis anterior, and extensor hallucis longus. Eversion is done by peroneus longus, peroneus brevis, peroneus tertius, and extensor digitorum longus. Now the function of the ankle joint. So ankle joint mainly does, as we just now discussed, the plantar flexion and the deep flexion. That is the action of your talocrural joint. So normal ankle joint range of motion is 10 to 20 degrees of dorsiflexion and 20 to 50 degrees of plantar flexion. Greater range of motion is obtained if measurement includes other joints also, like your subtalar joint or your transverse tarsal joint. Now we'll discuss about the osteokinematics of the talocrural joint. It possesses 1 degree of freedom. The axis of the ankle passes approximately through the fibular malleolus, body of the talus, and through or just below the tibial malleolus. It is bit inclines superiorly, slightly, and anteriorly as it crosses from the lateral to the medial side of the talus through both the malleoli. This is because the lateral malleoli is inferior and posterior to your medial malleolus structurally. That is why the axis is bit inclined. Here you could see the deviation from a pure medial lateral axis of the rotation about 10 degrees in the frontal plane and 6 degrees in the horizontal plane. If you see in the frontal plane, because the malleoli are bit up and down, you can see the medial one is up, the lateral one is down. So axis is bit 10 degrees. You can see in your frontal plane, and if you see the horizontal plane, you could see, because it is anterior posterior the malleoli, the axis is 6 degrees tilted. This oblique axis creates a motion across 3 planes. That is why we have a triplanar motion around a single fixed axis. So first is the dorsiflexion, which brings the foot up, and because one thing is up and second one is slightly lateral to the leg. Third turns the foot longitudinally away from the midline. This is the triplanar movement of dorsiflexion because of the oblique axis. Dorsiflexion is always associated with talar abduction, that is 10 degrees, and talar eversion 5 degrees or less than 5 degrees. This occurs because of the oblique axis. Then we have the plantar flexion. Again, plantar flexion will be done with 3 triplanar movements. First is foot goes down and then moves medial to the leg and then turns the foot longitudinally towards the midline. So plantar flexion is associated with talar adduction 7 degrees and talar inversion 5 degrees. When the foot is in weight bearing, in dorsiflexion, the leg moves towards and medial to the foot and rotates medially in the transverse plane. In plantar flexion, leg moves away from the foot and lateral to the foot and rotates laterally in the transverse plane. This was the basic osteokinematics. Now let us discuss about the arthrokinematics of the talocrural joint. During dorsiflexion, the talus rolls dorsally or forward and slides posteriorly. And during plantar flexion, the talus rolls backward and slightly anteriorly. Here you could see in this is the dorsiflexion. You could see the talus, it slides and rolls anteriorly. This is the plantar flexion and rolls posteriorly, slides anteriorly. Now, what are the factors that increase the mechanical stability of fully dorsiflexed ankle? First is the shape of the body of talus. The talocrural surface is wider anteriorly than the posterior part. So, when the foot is weight bearing on dorsiflexion, tibia rotates over the talus and concave tibiofibular segments slide forwards on the trochlear surface of the talus. The wider anterior portion of the talus wedges into the mortise. This enhances the stability of the ankle joint. Here you could see while you are doing a standing dorsiflexion, this is what happens. Though it wedges over the anterior part which is slightly big, so you have a good stability. The enhanced stability allows it to withstand a compressive force of over 4 times of the body weight. The slight spreading of the concavity of the mortise at maximal dorsiflexion causes slight movement of the fibula. The line of force of stretched anterior and posterior tibiofibular ligament and interosseous membrane produces a slight superior translation of the fibula. Like fibula is transferred superiorly to the proximal tibiofibular joint. Now, physiological function of the tibiofibular joints. So, we will be discussing about the inferior tibiofibular joint. During dorsiflexion, the lateral malleolus moves away from the medial malleolus. So, the fibula is pulled superiorly and is rotated medially while the fibers of the tibiofibular and interosseous ligament tend to become horizontal. During the plantar flexion, the malleoli are approximated because in the dorsiflexion they are going away, in plantar flexion they are approximated. Fibula is pulled inferiorly and is slightly rotated laterally while the ligament tends to become vertical. Next is the superior tibialofibular joint. During dorsiflexion, the fibular facet slides superiorly and during plantar flexion, the fibular facets slide inferiorly. Now, how the anterior-posterior stability of the ankle joint is taken care? It depends on first the gravity. Second, the anterior and posterior margins of the tibial surface forms which the bony spurs. Third, the collateral ligaments are passively responsible for the coaptation of the surfaces. Transverse stability of the joint depends upon the interlocking of its surfaces. 2 malleoli grip the talus on each side, providing the distance between the 2 malleoli unchanged. This condition is fulfilled only when the malleoli and the ligament of the inferior tibiofibular joint are intact, basically the interosseous ligament. Now, what are the factors which limit dorsiflexion and plantar flexion? So, factors limiting dorsiflexion are first the passive tension in the triceps surae, second posterior part of the joint capsule and posterior fibers of collateral ligament which are stretched properly, Third, the bony factors are the talus comes into contact with the anterior margin of the tibia. That is the shape of the talus, the anatomy of talus which we discussed earlier. Now, what are the factors which limit plantar flexion? First is the passive tension in dorsiflexors. Second, the anterior part of the capsule and the anterior fibers of collateral ligament are stretched properly to maintain that. And then the bony factors are the contact between the posterior lateral tubercle of the talus and the posterior margin of the tibia. So this was about the talocrural joint. Next is the subtalar joint. So subtalar joint or talocalcaneal joint is set of articulations formed by posterior, middle and anterior facets of the talus and calcaneum. Subtalar joint and joints of the foot complex perform a dual function. They have two types of functions. First is the orientation of the foot with respect to the other two axes in the space, and second is the adaptation according to the ground and acts as a shock absorber, which gives it a very important and significance in your ankle complex. So if we talk about the structure, the we have a talar articulating surfaces and calcaneal articulating surfaces. Talar articulating surfaces are the posterior surface which is concave, anterior surface and the middle surface which is convex. Calcaneal articulating surface are the reverse configuration of the talar articulating surfaces. We also have two basic structures here. One is the tarsal canal, another is the sinus tarsi. Tarsal canal is funnel-shaped tunnel between the posterior articulation and the anterior and medial articulation. Sinus tarsi is a conical hollow bounded by talus medially, superiorly and laterally with the superior surface of the calcaneus below. It lies just anterior to the fibular malleolus. Here you could see this is the sinus tarsi. It is a bony outcropping on the calcaneus. It bears an elongated articulating area which divides it into middle and anterior talus. Now the joint capsule, the tarsal canal and the ligament running through it divides the posterior articulations and medial and anterior articulations into two separate non-communicating joint cavities, anterior and the posterior. The posterior articulation has its own capsule. The anterior and middle articulations share a capsule with the talonavicular joint. So the talus acts as a distributor spreading the body weight and other loads on the entire foot, and the load is distributed in three major directions. Anteriorly and medially towards the medial arch through talonavicular joint, posteriorly towards the heel through the posterior joint, anteriorly and laterally towards the lateral arch through the subtalar joint. So what are the ligaments around this subtalar joint? It receives support from various ligamentous structures like the lateral talocalcaneal ligament, posterior talocalcaneal ligament, intraosseous talocalcaneal ligament and the cervical ligament. The lateral talocranial ligament is from the lateral tubercle of talus to lateral calcaneal surface, and it descends obliquely and posteriorly. The posterior talocalcaneal ligament is from posterior lateral tubercle of talus to the upper surface of the calcaneus. The medial talocalcaneal ligament is from medial talar tubercle to back of the substantia tali, and the fibers blend with the deltoid ligament. There is intraosseous talocalcaneal ligament which has got two bands, anterior band from sinus calcaneae just behind the anterior surface to sinus tali and runs obliquely, superiorly and anterolaterally, and a posterior band which is from sinus calcaneae to the sinus tali and runs obliquely from superior, posterior and laterally. We have a cervical ligament from the superior calcaneae surface to inferior lateral tubercle on the talar neck. It ascends superiorly and medially. So here you could see the ligaments around. This is the cervical ligament we just talked about. Now, what is the joint function of the subtalar joint? The arthrokinematics involves a sliding between three sets of facets. The alternating concave convex facet limit the potential mobility of the joint, and provides complex twisting or screw-like motions. This is triplanar motion around a single oblique axis, producing the motion of pronation and supination. So the axis pierces the lateral posterior heel. Here you could see the axis in the diagram. And courses through the subtalar joint in the anterior, medial and superior direction. The axis is deviated 42 degrees from horizontal plane and 16 degrees from the sagittal plane. Same as you see in the talocrural joint. The deviations cause a proper pronation and supination. So in pronation and supination, the oblique axis provides two components out of the three. First, inversion, eversion. Second, abduction, adduction. So it has a small component of flexion, extension also along with it. Here you could see the abduction, adduction, and here you could see the eversion and inversion around the AP axis, abduction around the vertical axis. Non-weight bearing talar motions, the motion of the calcaneus on the stationary talus is around the reference point from the head of the calcaneum. You can see here, this is the supination, the calcaneal eversion, abduction and plantar flexion. This is the neutral position, and this is the pronation where calcaneal eversion, abduction and dorsiflexion occurs. We all know that we have a triplanar rear foot motions. So pronation will have three movements over the three planes. When we say pronation, sagittal plane will be having dorsiflexion. At the transverse plane, we will be having abduction, and the frontal plane, we will be having eversion. When we say supination, sagittal plane, we will be having plantar flexion. Transverse plane, we will be having adduction, and frontal plane, we will be having inversion. Weight-bearing subtalar motions, calcaneus is free to move around longitudinal axis and limited in coronal and vertical axis. Inversion, eversion components occur at calcaneus and other two components occur at talus. So when we talk about the arthrokinematics, the medial and inferior glide of the talus occurs on the calcaneus with foot pronation, and the lateral and superior glide of the talus occurs at calcaneus with foot supination. The height of the talar head is changed from supination to pronation during the closed kinematic chain motions, resulting in the shock absorption. That is how it helps a lot in the movements of your ankle. When we talk about the closed kinematic chain, in pronation, there is plantar flexion and adduction of the talus, eversion of the calcaneum and internal rotation of the tibia. In supination, there is dorsiflexion and abduction of the talus, inversion of the calcaneum and external rotation of the tibia. So what are the range of motions at subtalar joint? Inversion is around 22 degrees and eversion is around 12 degrees. Abduction, adduction is around 38 and 33 degrees respectively. In the neutral position, we can be the subtalar joint can be defined for that joint as the position in which the foot is neither supinated and nor pronated. It is basically based upon the premise that foot is normal when subtalar joint positions are neutral. To find the neutral position, align the foot so that there is one straight line between the heel to the midline of the tibia. So you can see if you draw a line like this from just dissecting the heel and the tibia, that will make your subtalar joint in neutral position. Then we have the transverse tarsal joints, also known as the mid-tarsal or the chopard joint. It consists of two articulations, the talonavicular joint and the calcaneocuboidal joint. The horizontal S-shaped joint line divides the hind foot from the midfoot. We all know about this, that the foot is divided into three parts. The hind foot is the posterior segment composed of talus calcaneum. Midfoot is the middle segment composed of navicular, cuboid and the three cuneiforms. And the forefoot is the anterior segment composed of the metatarsals and the phalanges. Then the talonavicular joint. It is the articulation between convex head of talus and the concave posterior aspect of the navicular, and the dorsal surface of The plantar calcaneonavicular ligament. It spans gap between substantia tala and plantar surface of the navicular. It forms floor of talonavicular joint. The joint capsule is reinforced posteriorly by the interosseous ligament, dorsally by the dorsal talonavicular ligament, laterally by the calcaneonavicular fibers, bifurcating ligaments, and the medial capsule blends with the deltoid ligament. The dorsal talonavicular ligament from dorsal surface of the talar neck to the dorsal surface of the navicular. These are the ligaments around this joint. The plantar calcaneonavicular ligament and the calcaneonavicular fibers of bifurcating ligaments. These are the basic ligaments around the joint. Then we have the calcaneocuboidal joint. It is formed by junction of anterior surface of calcaneus and proximal surface of the cuboid. Articular surfaces have slight convex and concave curvature. It provides an element of rigidity to the lateral column of the foot. We have a joint capsule present which is reinforced by the laterally by calcaneocuboidal part of bifurcating ligament, dorsally by the dorsal calcaneocuboidal ligament, and inferiorly by other ligaments. So these are the basic joints which are present over the ankle, the talocrural joint, and subtalar, and the other surrounding joints. So I hope with this we could conclude the anatomy of ankle complex. If anybody has any doubt or anyone wants to ask any question, you could WhatsApp me, email me, or call me. Thank you so much. See you in the next class.